We're going to speak today about colonoscopy and the reason we do colonoscopy and basically how it works. So most of us are aware of a colonoscopy, that's examining the colon. The colon is about 1 meter long and it forms a large horseshoe going over the abdomen like that. Obviously starting at the anus and sort of ending where the appendix is. When we do a colonoscopy, we take a tube which is flexible and we look inside the colon. The problem with colonoscopy is that it has to be clean. So to clean out for a colonoscopy is not very pleasant, as we all know. You have to be on clear fluids for the day before the procedure, a fairly limited diet for a couple of days, and you drink fluid which doesn't taste very nice and makes your bowel go a lot, and it can be quite uncomfortable. But this is probably the most important part of any colonoscopy, is the preparation. So obviously if we go in and we go over here, inside there, and there's a lot of material there, we won't be able to see anything, and the quality of the colonoscopy is basically impossible. So you can't interpret what you see if the colon preparation isn't absolutely perfect. Basically what we do, patients come in, they've got a beautifully prepared bowel. We've got to make sure that they haven't taken anything by mouth, at least 6 hours, clear fluids about 2 hours. So the problem also with preparing for colonoscopy is that patients get thirsty and dehydrated. Essentially we can take clear fluids, which is things like apple juice and water, quite liberally till about 2 hours before the procedure. Sometimes this is a little bit difficult and patients struggle sometimes with nausea and feeling unpleasant. When you arrive in the colonoscopy theatre, we make you comfortable, put in an intravenous line, and then give patients sedation. Very few patients need general anesthesia. So in essence, we put a drip in, start some fluids which makes them feel better, inject some medication, patients fall asleep, and while they're asleep, lying on their left side, we examine the colon fully. Remember, the most important issue with colonoscopy is preparation. So we go in over there, all the way around. It can be very twisted and we basically end over there. Getting into the colon and reaching the end of the colon is important, but much more important is withdrawing slowly and carefully and looking underneath all these folds for things that we're concerned about. Mainly we want to find polyps. Obviously we're always concerned about colonic cancer, and then certain types of diseases like Crohn's, ulcerative colitis and diverticular disease. As mentioned in the previous lecture, diverticular disease is normally over there, little pockets in the bowel. They are very easy to see and we're not too worried about those. The polyps are very common, so we see lots of polyps over here. So a diverticulum is a pocket and a polyp is like a little mushroom over there. If we do see a polyp, we normally can take it off. Polyps can be all over the colon. You get polyps there, you get polyps there. You very seldom get polyps in the small bowel, which is there. So we can evaluate the entire colon. We don't evaluate the small bowel. We probably just look in this section of the small bowel, but obviously we can't go all the way up the small bowel. Standard length of the colon is about 1 meter, as we mentioned. The colonoscope is much longer than this, but we normally can get through the colon with a scope length of about 70 to 80 centimeters. When you push the colonoscope forward, you obviously come to certain twists and turns, but we have methods of sort of shortening the bowel, getting past these very tight turns. The most difficult turn normally is over here. We call that the splenic flexure. We have another difficult turn there, the hepatic flexure. The cecum is the sort of end, the cul-de-sac of the large bowel. Often we see pathology here because it's quite a large saccular type structure. You only complete the colonoscopy once you've been into the cecum and actually have looked into the small bowel. As I say, we withdraw the colon, we withdraw the colonoscope carefully, we look for polyps and any other pathology, and then we can reassure patients. The important thing about doing a colonoscopy is excluding polyps and excluding malignancy. If we do see a polyp, we can remove it. Mostly small polyps are really easy to remove. The great thing about taking polyps out is that small polyps, become big polyps, and big polyps can become cancer. If you keep polyps out of the colon, if you take the polyps out, then the chance of developing cancer is minimal. So regular colonoscopy, regular evaluation, depending on the guidelines and depending on what's going on in your large bowel, will prevent colonic cancer. And this is why colonoscopy is such a great procedure. Okay, so we've had a question which is a very good question about what exactly is the anatomy of the colon. So that's the anus, and that's obviously where we put the scope in. When we do the colonoscopy, patients are under blankets and everything happens in a very professional way. This is the rectum. So you go through the rectum and then there's a sharp turn. That section of the colon is called the sigmoid colon, and then this section is called the descending colon. So we get all the way up there, then you've got a tight corner, and this is the transverse colon, and then another tight corner, that's the hepatic flexure, because the liver is sort of there, and then you go all the way down into the cecum. As mentioned, this is about 70 to 80 centimeters in length. So you can see, looking at this picture, that if it isn't absolutely perfect, it's going to be very difficult to look under all these little folds, to go and look over these little corners. So preparation is absolutely crucial. It's a collaboration. So the patient does the preparation perfectly, and I can do my job happily and with great confidence. After a procedure, I will often say to the patient, thank you very much for the excellent preparation. The only difficult thing with preparation, which we sometimes see, is when patients have severe diverticular disease with lots of little pockets there, the pieces of fecal material get stuck there, and then quite often during the colonoscopy we put air into the colon, and then these little pieces jump out into the bowel, into the where we're looking, and that can be very, very difficult. So sometimes they get stuck to the camera that we use, and it can be extremely challenging. But that definitely is not the fault of the patient, it's the fault of those diverticular disease areas.